no exposure of the dental pulp occurs, it is called uncomplicated fracture, and complicated means there is definite involvement of the pulp. Now uncomplicated can be of two types, involving only the enamel and involving both enamel and dentine. In the question that was asked, it was asking uncomplicated crown fracture that was involving dentine. So if this is a tooth, suppose, and this is the fracture that has occurred, this is the pulp organ of the tooth, then this is the dentine which is exposed. This is the enamel cap and the dentine has been exposed. Okay, so whenever the dentine is exposed, there are open dentinal tubules that can serve as a pathway for inflammation, infection, bacteria, etc. from the exposed surface to the dental pulp. So we have to protect the pulp to prevent the infection and inflammation of the pulp. So the options given were dentine bonding agent, light cured GIC, chemically cured calcium hydroxide, and light cured calcium hydroxide. If I speak technically, all the options are correct for an uncomplicated crown fracture because all of them can be used as agents for protection of the pulp by sealing the overlying dentine. Okay, if I look at the options C and D, they talk about calcium hydroxide. Calcium hydroxide is used as a liner to seal the dentinal tubules whenever the distance between the pulp and the exposed surface is less than 0.5 millimeter. So there is a specific condition when the remaining dentine thickness over the pulp is less than 0.5 millimeter, we use calcium hydroxide. If we look at the language of the question, nothing was related to the depth of the exposure, simply it was saying that dentine was exposed. So since specifically it was not given what about the remaining dentine thickness, we would treat it as a lot of dentine is available which is well above the range of 0.5 millimeter. So we are left with options A and B. Out of the options A and B, light cured GIC is a better option, so should be the answer over here, because simply putting a dentine bonding agent, had it been dentine bonding agent plus resin based composite, if the option was like this, then A would have been a better option. Okay, but as you can see, it was given only dentine bonding agent, so placing the dentine bonding agent simply is not very effective in sealing the dentinal tubules. So to protect, we have to use a light cured GIC. So the answer to this question would be option B. Okay, you have to simply remember that uncomplicated crown fractures means not involving the pulp, and if it is asking about remaining dentine thickness less than 0.5 millimeter, then you have to use calcium hydroxide, and out of that also light cured calcium hydroxide is a better material as compared to chemically cured calcium hydroxide. Coming over to the next question, the perforation in which region of the root has the best prognosis? Now it is asking about prognosis. Perforation has which region has the best prognosis? We all know that if this is the root of a tooth, okay, it can be divided into coronal, middle and apical 1/3. This is the coronal, this is the middle 1/3, and this is the apical 1/3. Now best prognosis for the fracture to occur, we know that whenever fracture or perforation occurs, there is talking about perforation. See, the perforation whenever occurs apically in the root, majority of the attachment apparatus remains intact. So the prognosis would be better when it is in the apical 1/3. It would be poor in the middle 1/3, and prognosis would be worst. I am talking about the prognosis for the perforation to occur would be worse in the coronal 1/3. Okay, you don't have to get confused because apical 1/3 of the root is most difficult to approach. So if a perforation occurs in apical 1/3, it would be definitely more difficult to repair and seal as compared to that occurring in middle and the coronal 1/3. But if we talk about the prognosis, even if we are not able to successfully close the perforation with some repair material, then also the prognosis would be best in the apical 1/3. So the answer to this question would be option A. Prognosis for a perforation is best in the apical 1/3. Coming over to the next question. In which type of suture material is microbial transmission and the wicking effect is evident? We know that what is wicking effect? Wicking effect is the capillary action that would result in suction of tissue fluid, microbes, etc. through the suture to the site of surgery or wound. Synthetic monofilament sutures, plain gut sutures, Teflon sutures, or silk sutures. Okay. Out of these sutures, you can make out that it is the silk suture, which is a microfilament braided suture. Braided suture means numerous threads of silks, they are interwoven, they are twisted together. So whenever these numerous small threads of natural silk, they are twisted together to form a thread or suture, definitely they serve as microscopic pathways for the percolation of fluids across them. So they have got a wicking effect. Answer would be D, option D, that is the silk suture has a wicking effect. So a relatively straightforward question. Teflon is a polytetrafluoroethylene, PTFE, which is a synthetic suture. Okay, plain gut sutures, again they are smooth because they are coated with chromic acid and all. And synthetic monofilament sutures, since it is a monofilament suture, not a braided suture, it does not give rise to wicking effect. Wicking effect would be there when the microscopic channels are present between the threads of the suture. So the answer would be silk suture. Coming over to the next question. What is the recommended treatment period for lateral luxation? It is asking you, it should be either splinting period. I do not know what was the exact language of the question, but it is in a way generally asking about the duration recommended for these luxation injuries, that is particularly lateral luxation. Now, if we talk about luxation injuries, we know there are different luxation injuries like concussion, okay, subluxation, lateral luxation, isn't it? Extrusion and intrusion. These are the different types of luxation injuries. And if I talk about the severity of injury, then the severity of the injuries increases from concussion to intrusion. Intrusion is the most severe form of luxation injury, and concussion is the least severe form of luxation injury. Now the question is asking about lateral luxation in the splinting period. The options, 2 are related to rigid splinting, 2 are related to flexible splinting. What is flexible splinting? Flexible is a passive physiological splinting that allows for the physiological tooth movement. So always remember that we have to choose a passive physiological splinting for all cases of trauma. Okay, so we would rule out options A and option C, which are talking about rigid splinting. Okay, why do we not give rigid splinting? Because a rigid splinting which is done with a thick wire or immobilizable component does not allow normal physiologic tooth movement, and because of that there are risk or chances of tooth ankylosis and tooth resorption. So to prevent that in all forms of trauma, we would prefer flexible splint only. So the options left are B and D. The second part of the option talks about the duration of splinting. That you should know, one is talking about 4 weeks, another is talking about 2 weeks. Now, International Association for Dental Traumatology has given different guidelines for the duration of splinting in different luxation injuries. If I talk about subluxation, if at all splinting is required, it would be for 2 weeks. For lateral luxation, it is for 4 weeks. Extrusion, it is 2 weeks. And intrusion, it is 4 weeks. Concussion does not require splinting. So out of the 4 luxation injuries, 2 subluxation and extrusion require splinting with a semi-rigid or flexible splint for 2 weeks, and lateral luxation and intrusion require for 4 weeks according to International Association for Dental Traumatology. So the answer to the above question would be option B, that is flexible splint for 4 weeks. Answer is option B. Okay. Coming over to the next question. According to Vertucci's classification, which type describes a single root with a single canal that splits into 2 canals? Again, a straightforward questions, and this Vertucci classification we have seen many times as one of the favorite questions both for your NEET pre-PG examinations as well as for INICET examinations. And it is a relatively simple thing. Vertucci's classification gives classification configuration into 8 types. Okay, and it is talking about a root with a single canal that divides into 2 canals. Okay, which type? Now, if we revise the Vertucci classification, then the type 1 is single one canal, means there would be a root with a single canal. Vertucci type 2 is a 2-1 configuration. Okay, 2-1 configuration means a root with a 2 orifice in the coronal, 2 separate canals emerge and they join and exit as single apical foramen. Vertucci type 3 is a configuration that is 1-1 configuration. 1-1 means in the root of a tooth we see a single coronal orifice, a canal emerges, divides and again joins and exits as a single apical foramen. 1-1 configuration. Vertucci type 4 is 2, means a single root of a tooth consists of 2 separate canals which exit as 2 separate apical foramen. Vertucci type 5 is reverse of type 2, that is 1-2 configuration. In the root of a tooth, a single canal originates, single orifice is there, it later divides and exits as 2 apical foramen. So this was asked in the question, basically a single canal that splits into 2 canals. You can see coronally there is a single canal, it splits into 2 canals, so it would be option A, that is Vertucci type 5. If we revise the remaining types, then the type 6 is 2-1-2 configuration. Type 7 is 1-2-1-2 configuration, and Vertucci type 8 is 3 configuration. 3 means in single root of a tooth there would be 3 separate canals exiting as 3 separate apical foramen. So for answering this question, you had to be familiar with the Vertucci's canal configuration, which divides the canal configurations into 8 types. And I have already told in the classes also that the tooth which has shown all the possible Vertucci canal configurations is maxillary second premolar. This is the tooth which shows all the possible 8 canal configurations according to Vertucci. So the answer in the above question would be type 5, 1-2 configuration. Coming over to the next question. A patient with pulp exposure has calcium hydroxide applied directly to the exposed pulp to preserve its vitality. What is this procedure called? A very straightforward and simple question. In direct pulp capping, partial pulpotomy, direct pulp capping, or SVEC pulpotomy. Okay, patient with pulp exposure has calcium hydroxide applied directly to the exposed pulp. Definitely it is direct pulp capping, a part of vital pulp therapy called direct pulp capping. It is a self-explanatory question with a very straightforward answer to it. Option C is the answer to the above question. Coming over to the next question. The thickness of MTA plug in Apexification is, this is also a relatively straightforward question. 1 to 3 mm, 3 to 5 mm, 5 to 7 mm, or depends upon the root length. Now basically Apexification is the procedure to form an apical barrier in immature pulpless teeth. Okay, so there is a immature means open apex tooth in which we are doing root canal. So we would form an apical barrier of a material that promotes calcification. Previously we have been using calcium hydroxide based preparations or calcium hydroxide material which were used for long terms of 16 to 18 months and resulted in unpredictable calcific barrier formation. Now with the advent of MTA or calcium silicate based materials, what is MTA? MTA is basically a calcium silicate based material. We can do apexification in a single visit and more predictable manner. Generally, the thickness of apical plug is 4 mm, which is done in cases of apexification. So if we look at the options, 3 to 5 mm is the range that is the best possible answer over here. If a single option you have to choose, and if they come, then 4 mm is the standard thickness of the MT apical plug recommended for apexification. Coming over to the next question. Sorry, this question is a repeat. I am skipping this. Question number 9. The type 3 transportation of the canal is best repaired by. Type 3 transportation of canal is best repaired by. Transportation means it is talking about apical transportation. Now this is something which is related to management of endodontic procedural mishaps. Okay, we all know that in the root of a tooth, okay, the canal is like this and it exits at the apical foramen. Especially in the cases of curved roots, if we are not following the root canal curvature, we are using a straight file in a curved root canal, we are using a stiffer file in a curved root canal which is not bent according to the canal curvature, then we are likely to straighten the root canal and transport the apical foramen. Okay, if I am using a stiffer file, the stiffer file, a straighter file would go like this and it would relocate the apical foramen over here. This is called transportation of the physiological apical foramen from its original position to a iatrogenically created position. This apical transportation is basically of 3 types. Type 1, 2 and 3. Based upon the severity of apical transportation, it is divided into 3 types. Apical transportation is of 3 types. Type 1 is a mild form of apical transportation of the foramen. Type 2 is a moderate one, and type 3 is a severe transportation of the apical foramen. Now the question is asking about the management of type 3, which is the severe form. Type 1, which is a mild, if we talk about its management, it is simply renegotiation of root canal coronal to transportation. We would renegotiate the root canal coronal to the transportation with larger file size and obturate it. It is a easily manageable situation. Okay, suppose this is the root canal and there is a minor transportation from here till here of the root canal. Then what we would do, we would re-establish the working length short of the original length. This was the original working length. We would re-establish the working length short of the original length and enlarge the canal to create an apical stop above the transportation. Because of the transportation, you are likely to go beyond the apical foramen into the PDL. So what we have to do, we have to simply shorten the working length, enlarge the canal to a slightly larger size so that an apical stop is created coronal to the perforation or transportation, and then we simply obturate it in a conventional manner. This is simply the treatment for type 1 transportation. For type 2, which is a moderate, we have to use a barrier material. Simply coronal preparation and obturation is not sufficient. Because of the moderate intensity of transportation, we have to use a barrier material. What is meant by barrier material? Suppose this is a case of transportation type 2. Then a good amount of transportation has occurred in the root canal from here till here. This is the original apical foramen and this is the iatrogenically created apical foramen. So moderate amount of transportation has occurred. Simply preparing the root canal is not enough to a larger size. We have to seal the transportation perforation with some barrier material. So what we do, the most commonly used barrier material is MTA, mineral trioxide aggregate. It is pushed through the root canal and a MTA plug to seal is created, followed by coronal obturation of the root canal. So what is the management? We have to use a barrier material. If I talk about type 3 transportation, that was asked in the question also, which is a severe form of transportation. It's a severe form of transportation. Then it is such excessive or extensive transportation that a placement of barrier material is very difficult or at times is not sufficient to seal the transportation. We have to use surgical repair. Okay, so what is the treatment? We do root canal obturation, which is followed by surgical repair of the site. We have to gain entry to the creating window in the bone and surgically repair the site with one of the materials. So coming back to the question, type 3 transportation, MTA plug is for type 2, isn't it? It is for type 2. Surgical correction and apical resection is the answer over here. Option B. Apexification again is related to apical MTA plug formation, one and the same thing. We do it for type 2 transportation. Extraction is the last resort, is not the management, and warm vertical compaction is a method of obturation, not the management of type 3 transportation. So what would be the answer over here? Answer over here would be surgical correction or apical resection. Technically speaking, this question is related to some advanced levels of endodontic practice, means whenever we have to manage certain procedural errors in an advanced manner. Ideally, they should not ask for the pre-PG examination, but definitely we cannot help it. And if we have to talk about transportation, I have given you all the possible explanations for them. Coming over to the next question. The best treatment for cracked tooth with reversible pulpitis. It is reversible pulpitis. Basically pulp hyperemia or reversible pulpitis, but the tooth is cracked. Okay. It is not a craze line, but a complete crack in the tooth. So what are the options? Full coverage crown, a resin or composite restoration, bidirectional splint or double splint, okay, stainless steel splint or single splinting. See, splinting of the tooth is done for the periodontally compromised teeth in the cases of luxation injuries or periodontally compromised teeth. Whenever the attachment apparatus of the tooth has suffered, we would do splinting. So we rule out the options of splinting. We are left with two options for a cracked tooth with reversible pulpitis: a full coverage crown or a resin or composite restoration. See, whenever there is a crack in the tooth, that is likely potential of because of the masticatory forces or movement, it would cause tissue fluid movement or percolation, and the widening of the crack, etc. can occur. So we have to basically use a full coverage crown to stabilize the tooth, prevent the communication of crack with the oral cavity, as compared to resin or composite restoration. Okay, so the answer to this question would be full coverage crown that protects the tooth on a whole. There's a crack in the tooth, we put a full coverage crown. It is like a helmet on the tooth that would prevent the not only the movement of the tooth fragments, but also the progression of the crack further. So if at all it is a salvageable tooth with a crack, the full coverage crown is the best option. So answer would be option A. Coming over to the next question, which is again a slight variation of one of the questions already discussed. For uncomplicated crown fracture, what can be done to avoid pulpal inflammation? Okay. Based upon the recalls, two versions of this question have been given. Again, the calcium hydroxide light cured and self cured, we have already discussed. Uncomplicated crown fracture, calcium hydroxide would be given only when remaining dentin thickness is less than 0.5 millimeter. Options left are GIC, self and light cured, resin and composite. Now in this version, resin and composite is there. So definitely E is a better answer as compared to C. A bonding resin followed by composite restoration is a more durable and better treatment for an uncomplicated crown fracture to prevent pulpal inflammation due to fluid movement through the dentinal tubules. The second best answer is GIC light cured. So if resin and composite is there, that would be the first choice answer. If that is not there, GIC would be the first choice answer. And if the various versions of GIC is given, then definitely light cured is a better than self cured GIC. Next question. For severely intruded tooth with closed apex, again a question related to endodontic traumatology. Tooth intrusion, the most severe form of what? Intrusion or luxation injuries. With a closed apex means a mature tooth is there. When should the root canal treatment be done? See, we have already seen that intrusion is the most severe form of luxation injuries, and the question itself is talking about a severe form of intrusion. Severe form of intrusion means a fully formed tooth with a closed apex is severely intruded, means the pulp necrosis is most likely. Such a tooth is not likely to survive, in the sense the pulp is not likely to remain healthy because of the severe intrusion of the tooth. The pulp necrosis is most likely, and whenever the pulp necrosis occurs, we have to do root canal treatment. Now when should the root canal treatment be done? After 4 weeks, immediately after repositioning of the tooth, within 2 weeks, or only when the patient complains of pain. See, it is almost certain that whenever a severe form of intrusion occurs because the tooth has hit the bone in the apical 1/3, there would be pulp necrosis. And whenever pulp necrosis occurs and we do not do the root canal treatment, that necrotic pulp would likely to induce inflammatory root resorption. So to prevent the inflammatory root resorption and save the tooth, we have to do root canal treatment immediately after repositioning of the tooth. This would prevent what? Prevent inflammatory root resorption. So immediately has to be done, preventing inflammatory root resorption and improving the survival potential of the tooth. So the answer to this question would be option B. Okay. See, intrusion can be mild, moderate, and severe. Mild intrusion is less than 3 mm intrusion. 3 to 7 mm intrusion is moderate, and greater than 7 mm intrusion is what? Very severe form of intrusion. So for repositioning of the tooth, mild intrusion, it can auto erupt. The tooth can auto erupt. Most of the time it may not require repositioning by the dentist. Moderate, we have to do some form of intervention to reposition the tooth. This can be either orthodontic extrusion or surgical repositioning. Whenever severe form of intrusion occurs more than 7 mm, it always requires surgical repositioning. So depending upon the severity of the intrusion, we have to choose the treatment modality, and the duration of splinting after reposition remains the same. That would be 4 weeks of physiological passive splint. All these recommendations are according to International Association for Dental Traumatology. Okay. Question number 13. A tooth with lateral luxation over a decade back. Now it is showing discoloration. The patient is asymptomatic. On IOPA there is obliteration of the pulp canal and the periapical index score is 2. What is the treatment? Okay, there are 3 things basically given. A long history of lateral luxation, tooth discoloration. Discoloration basically indicates a non-vital tooth, means the pulp has become degenerated or necrotic. Patient is asymptomatic, no pain or anything, and there is obliteration of pulp canal. This is calcific metamorphosis of pulp. Calcific metamorphosis of the pulp. The periapical index score is 2. Okay, what is the treatment? We have to wait and watch, do root canal or do pulpotomy. See, when the obliteration of the pulp canal is there, doing a root canal treatment can be a difficult job for this case. Okay, since the patient is asymptomatic and periapical index score is 2, there is a mild form of pathology. A score of 0 means healthy periapex. Score of 1 is mild pathology. Okay, so we have to simply treat it in the coronal part, followed by some form of restoration, aesthetic treatment for the discoloration. If the periapical index score is moderate to severe, then we need to do surgical intervention for such a tooth. Okay, So the treatment choice would depend upon whether there is a periapical pathology that is severe or not. If a severe periapical pathology is present, and even though the patient is asymptomatic, we have to manage it surgically to remove the periapical pathology. Why surgically is removed? Important because there is obliteration of the pulp canal. We may not be able to negotiate it to the apex in an orthogrid manner, so surgical intervention would be required. Coming over to the next question. Sodium hypochlorite irrigation depends on. I do not know what was the exact language for this. Depends on or is influenced by the pH, temperature, volume or concentration. See, for endodontic irrigation we use normally 0.5 to 6% sodium hypochlorite. Excuse me. 0.5 to 6% sodium hypochlorite is used. And irrigation, we all know that most important aspect for irrigation is the flushing of root canals. Okay, we do flushing of the root canal. Flushing of the root canal means we have to use copious volume of the solution to flush out the root canal effectively. Okay, so one definite thing would be volume, option C. Looking at the other options, pH of sodium hypochlorite is generally in the range of 9 to 11. It is an alkaline solution, highly alkaline solution, which do not normally influence the irrigation. Temperature has a definite influence that efficacy of sodium hypochlorite. Okay, it increases to almost twice for every 1 degree Celsius increase of temperature. Whenever we increase the temperature by 1 degree Celsius, the efficiency or the efficacy to remove the necrotic debris from the root canal, dissolve the pulp tissue, is almost twice, and this is generally in the range of 5 degrees to 60 degrees Celsius. So heating sodium hypochlorite definitely increases its efficacy. Concentration, we have seen that we use in the concentration of 0.5 to 6%, but the concentration of sodium hypochlorite, although has an influence, does not have a major influence on the efficacy of irrigation. So option B, that is temperature, and option C, volume of irrigation, have a definite influence on the success of irrigation. So B and C, option B would be the answer to this question. Okay. Question 15 I am skipping. This is again the repeat of already what we have discussed. Coming over to the next question. The root canal morphology of MB root, mesiobuccal root of maxillary molar, is influenced by or depend upon. Now this is a very unique question which has come in the examination. It is talking about the morphology of mesiobuccal root of maxillary molar. Root canal morphology. Distance between MB1 and MB2 canals, the depth of MB2 canal, the length of mesiobuccal canal, or the angulation of mesiobuccal canal. We all know that a maxillary molar, as seen from above, the mesial, distal, the buccal and the palatal aspects. This is the oblique ridge. This is the shape of access cavity, which is rhomboidal in shape. It accommodates the palatal canal, the mesiobuccal, the distobuccal canal, mesiobuccal, the distobuccal, and somewhere here is the MB2 canal. Okay, MB2 canal. This is about 2 mm mesially and 3.5 mm palatally to the mesiobuccal canal. Normally the two dimensions are 2 mm away and 3.5 mm palatally and 2 mm mesially to the MB canal. So the distance between these two canals is the factor which influences the root canal morphology. If the distance between the two canals, MB1 and MB2, is more, it is talking about root canal morphology. Root canal morphology can be, if suppose this is a mesiobuccal root, MB1 and MB2 canals, they can be like this. They can join together. If the MB1 and MB2 canals are too far, they can exit as two separate canals to the apex. So depending upon the distance between the MB1 and the MB2 canal, the root canal morphology of the mesial root of mesobuccal root of maxillary molar changes. So option A is the answer to this question. Okay, the root canal morphology depends upon the distance between the two orifices. If they are close together, they are more likely to join. If they are separate, they are more likely to exit as a separate canal to the apex. The next question and the last question, the material used for air abrasive polishing is air abrasive polishing. Now I do not know whether the exact combination of these two terms was there. Air abrasion or polishing, air polishing was sodium chloride, sodium bicarbonate, sodium citrate, or sodium fluoride. Straightforward answer would be sodium bicarbonate. We use sodium bicarbonate particles for air polishing. If it is simply air abrasion, okay, or kinetic cavity preparation or sonoabrasion, if the word polishing is there, sodium bicarbonate particles. If only air abrasion is there, then we use alumina particles. Alumina particles are what? Aluminium oxide particles. Usually 25 microns are used. Okay, one is air abrasion, one is air polishing. For air polishing we use sodium bicarbonate particles, so answer would be option B. Anyways, aluminium oxide was not there in the options. Okay, so this is all about the various questions related to my subject that were asked in the examinations. A couple of them were definitely tough, but majority were the straightforward. If you had gone through the class notes properly, would have been able to answer them very well. With this, I am closing this session. Thank you very much for being with me. Wishing you all the very best. Thank you.